Okay, our presenter this morning is Paul Cantrell. Paul has been a business acumen consultant to N4A for more than 8 years. Prior to consulting, he served as Health Policy Director for the Georgia Insurance Department, Vice President of Product Development for a statewide coalition of Georgia's largest corporations, and Corporate Director for Humana. And with that, I'd like to turn the floor over to Paul Cantrell. Welcome, Paul.
Thanks, Steve, and thanks to ASA. Also want to thank the Business Institute and, as you described there, the great funding and support from the John A. Hartford Foundation, the SCAN Foundation, and ACL for this opportunity to discuss contracting. This webinar represents the beginning of a focus for the Business Institute on contracting, and it will soon be followed by a toolkit on the Business Institute website. Today, though, we'll literally fly through the landscape of contracting. If you read the description of what we're going to talk today, I'm sure each of you that saw that thought, how in the world are they going to get through that in an hour? Well, I've wondered the same thing. So hopefully by the end, you'll think that we have done a nice job of taking you through at a high level, and then you'll be able to turn to the toolkit as it comes out soon on the Business Institute website to talk about additional features. And the first three pieces of those, general contracting, insurance requirements, and a lexicon of contracting terms, is going to come out soon. And then we also have technology and security that is on the drawing boards to add to that. So we're going to be building this on the Business Institute website, and we hope you find it very productive. And so thinking in terms of things like contracting and legal requirements and that kind of thing, we're going to get started with a disclaimer. I am not an attorney. I have never played a lawyer on TV. And this presentation offers only general guidance. It is not legal advice. As with any contracting requirements, whether it's in this context or any other, you certainly, I'm sure you all do, but we just want to make sure you want to talk with your local legal counsel who's admitted in your state to practice law in the applicable jurisdiction in which you're talking about doing work, and that they're experienced in the types of contracting that you're going to work on. And with that, I want to turn to this. Is this a new world that we're dealing with in new terms? It's an alphabet soup. And this, if you look at what's on the screen now, this is just covering privacy and IT-related terms. I'm sure if you look through this, there are things here that terms you may not be familiar with, or maybe you just don't know for sure what that means. I'll give you the example here of downstream risk. What does that involve? What's an FDR? What is pen testing? All of these types of things are things that you're going to need to become familiar with if you're not, and you get into this contracting world. And so we're going to try to, again, hit the highlights today, and hopefully the toolkit will take you to the next level there. And we certainly look forward to your questions at the end. We've got a lot to cover in a short time, and much of what we will cover is designed to provide, as I said, just kind of that basic high-level overview. But I want you to think of this a little bit as a checklist, and I would encourage you to download the presentation, because as you'll see on some of the slides, I've listed out different things that you should think about when you're entering contracting situations. So I encourage you to do that. And if you're taking notes, take them on the high level. Don't worry about writing down everything I say. Pull down that presentation and use that as a template there. So, contracting, first things first. Contracting with payers is not the end goal. It's a means to the end, and I think this is really important. When I talk to CBOs out there, community-based organizations, if any of you are not familiar with that term, one of the things that I find is that there is some anxiousness that's going on out there. We've got a contract. We've got to do this with payers, and we got to make this happen. And it is a really important priority, but you need to make sure that you're doing that within the context of what makes sense for your organization and what makes sense in terms of delivering on your mission. So I want to suggest that you start with,
and I'm going to need your help with it.
Why are you doing it? Does your organization have a strategic plan, and does what you're talking about doing fit in that strategic plan? Now, that doesn't mean, if the answer to that no, that you shouldn't do contracting. It means you go back and look at your strategic plan, and should contracting be part of that? Do you know what you do well and what you don't do so well, because that's part of what you are going to negotiate with a payer or a health system in meeting their needs. Are these things that you do well and you think you can deliver on? Because execution is the key to being able to maintain those contracts over time. Does it fit, as I mentioned a moment ago, in with your agency's mission? Really important. Steve? I'm hearing background noise. Okay, that's gone. Thank you. And do you understand what the expectations are, and can you deliver on those? Now I want to turn to some specifics, and specifically to the types of agreements. Again, when I talk to CBOs, this litany that we're going to go through here often is a little surprising because things start to hit fairly early in the conversations. And I want you to be aware, if you've not been doing contracting, what to expect, kind of when to expect them, and why. So, memorandums of understanding or letter of intent. Some places use these terms interchangeable. Some only use memorandum of understanding. Some use letters of intent, and it's often driven by your state or your jurisdiction that you're in there. But the one place that these are sometimes different is that in some jurisdictions, a memorandum of understanding does carry some binding intent to actually end up in a contract. But if you think about this at a high level, this is the two organizations, your organization and whatever organization you're talking to about contracting. You are putting in writing your agreement to reach a contract. So you've got to at least have reached the point that you have an idea of what you're going to contract to do. You're not just agreeing that you're going to be part of their network, for example. Though you might get that request from a managed care organization, you want to understand what your role will be. And it doesn't have to be all the details at this point. As a matter of fact, shouldn't be, because neither one of you have time to do that at this point. But you do want to have a general idea of what they want you to do. Do they want you to be their meal provider in X county? Do they want you to provide care coordination services for all of their members or some subset of their members? What are they thinking? And does that fit, again, with what makes sense to you from a contracting standpoint? Now let me explain why you might get fairly early in discussions or requests from this, especially from Medicaid plans. If you haven't already experienced this, the plans have to put together a network of providers that they will submit to the state. And they are trying to show, when they're submitting their bids to the state, that they can actually put together a network, that they do have that capability of constructing that network so that the state will take them seriously. And your letter of intent, or MOU, is going to be used by that managed care organization as part of the demonstration that, yes, that they are submitting their response to the RFP with good faith intent and belief that they can actually execute, that they do have providers that have shown intent to contract with them to provide the services that the state's requesting, and they're able to do it geographically where the managed care plans applying. So that's the purpose, that's the reason that you would do a letter of intent. Now, next I want to talk about non-disclosure agreements. And this, frankly, is the one that will probably happen first. And there's two things to think about with an NDA. One is that it happens pretty quickly. So maybe even by the second time you talk, you'll want to have an NDA in place. It can happen that fast. The other piece to think about with NDAs is that do not sign one that is not bidirectional. And by that, I mean that some organizations, the initial NDA that they might put in front of you says that all of their information that they discuss is private.
Basically, this thing is acting up.
Sign here. Well, the problem with that, of course, is you're going to bring things to the table that are part of your business model, that are your value. And if you're bringing those to the table, those need to be protected as well.
No, I understand.
So you want it to be bidirectional. If it's protecting them, that's great.
No.
It should be protecting you and your information as well.
There is a problem.
So make sure that you have a bidirectional NDA in place. And if they don't ask for one, if if you
bar
had a
popped
really
up,
good first conversation,
and I can't get it
oftentimes my
to go
experience
away.
is at the end of that first conversation, if everybody's agreeing we're going to have a further conversation, we're going to discuss a little bit more about what we'd like you to do and how you'd like to do that, and you're going to come to the table with these are the things we think we're really good at, and we can do it here, but we probably are a little thin over in this county, that kind of thing. You want to have that NDA in place. So coming out of that
Yeah,
first
I
meeting,
thought I
that
had
may be
turned
one
everything
of
off,
the
and
action
apparently not
steps
that one.
leading up to your second meeting with them. So it does happen really fast, and it's good for both organizations.
Thanks.
Now, business associate agreement. And as I start this, I think some folks seem to get confused between a BA and a BAA. BA is the business associate, and I'll describe what that is in a minute. The BAA agreement is the actual legal document. So why do we have these things, and what are they, and is it do you need to get one signed, the MCO to sign yours, or do you need to get downstream? How does this work? Well, HIPAA requires this, and they require it of three types of organizations: healthcare providers, health plans, and healthcare clearinghouses, so the ones that move the data that has PHI in it. PHI being, of course, personal health information. So those three types of entities, providers, plans, and clearinghouses, are what's called covered entities. And I'm going to stop for a moment and again plug what's the resource guides and the toolkit that are coming to the Aging and Disability Business Institute and the lexicon out there, because covered entity is one of the things described or defined in that lexicon. So is PHI. So is BAA. So if you need to better understand these, look for that lexicon coming soon and download that. And that is also going to be a very dynamic. Options are here. Those are general. Sometimes in jurisdictions, specific states, even county level, you could have a further definition from what is kind of the big picture national scope, what is typically used there. But the BAA, coming back to this, what it really does is it says that you're taking on some of the privacy and security responsibilities of the entity that you're contracting with that is governed by HIPAA. So the health plans and the providers, for example, have very specific HIPAA guidelines that they have to comply with for how they treat the information with any data that you get from them related to their members or patients. So it's a very serious associate agreement. Yeah, that's all I want to cover on that one. Next slide. Now, sometimes, just so we're clear, that also that BAA may be inside the Master Services Agreement, or it may be a standalone document. It's not always standalone. It's not always inside a Master Services Agreement, but it often will appear inside that Master Services Agreement. The Master Services Agreement, if you think of that as kind of the big picture roadmap. So this is the interstate highway system. It's going to define the big picture of general provisions, how the parties work together, what the payment terms are, so how quickly they're paying you, how quickly you need to get invoices in, what are termination provisions, dispute resolution, all of those types of things go into a Master Services Agreement. Oftentimes, and it'll normally be constructed this way, if the thought is that you're going to start with one type of work that you're going to do for them, but you may do multiple types of work. So the Master Services Agreement is a convenient way to lay down that interstate system of how you guys are going to work together. But it does not typically go into the actual work if it is constructed as a Master Services Agreement and then a scope of work. If it is a one-time, like a pilot or something like that, or something that may not have multiple types of work involved, then you may see the Master Services Agreement, and what I'm going to talk about next, which is the scope of work. You may see that in one agreement. But generally, my experience is that there's a Master Services Agreement. You get that worked out, and then you add the scope of work to that. And the scope of work then defines the actual work that you're going to be doing under this project. So, for example, you might be doing a transitional care program for them, for a managed care plan with certain members to go from hospital to home. This scope of work should define the details of that work. And in some places, it may be called a work statement or a statement of work rather than a scope of work. But generally speaking, those terms are used. Now I'm going to jump from the actual contracts and the type of contracts, and we're going to start talking a little bit about what the payer's requirements are. And so let's assume for a moment that you're in negotiations with a payer. It's really important that you do your homework to understand the payer's needs or their requirements. Think of this as the big picture. What are their expectations? What are they going to be facing, and how do you be then a solution for them in that work? So, and this sounds silly, but it's really important. Read the agreement. And when I say the agreement, I don't just mean the master services agreement or the scope of work, but understand what they are looking at, what they're responsible for, and we'll talk about that in just a minute. But when you're reading just that master services agreement that they put in front of you, because they generally all have a boilerplate agreement that they will be their starting point. Here's our contract. Sign here. Well, do you have a review process? So, and who's involved in that? Operations. Obviously, you want the people who are going to actually do the work to take a look at the scope of work. They may not need to look at what the payment terms are, but they certainly need to be looking at what is the actual work, and how does that work with the way we do business and how we do things? What would we have to change? Are there things we should go back and say, well, we don't do it exactly that way, we do it this way, would that be okay? Those types of discussions, managed care organizations and health systems are very accustomed to having discussions around, and there will be a little stress points if you want to change things too much, because standardization means a whole lot to a managed care organization and to a health system. So they don't want to, from a process standpoint, change a lot of things, but they will obviously sit down and hear you out in those things. You want your finance people to be looking at the payment terms and the financial side of this, the legal folks to look at the legal. Don't forget insurance. And there's two pieces there. One is what is being required of you to carry insurance, because there will be some insurance provisions in the agreement and expectations that you have certain types of insurance. But talking to your insurance folks about the agreement itself, share the agreement with them and ask them to give you a risk assessment. What types of risk are you assuming that maybe you haven't thought about in that? And if this involves you having downstream providers and certain expectations that don't fit with what your relationships are today, I'd have some discussions with them. Don't just assume that they can do things in a different way if there are different requirements in this agreement. And probably the most important thing on this slide is to be determined later is not a contract provision. If it matters, get it in writing and get it in the agreement, especially when it comes to things like performance metrics and what you're going to be measured on. Now, as I mentioned a minute ago, doing your homework, looking at what the state contract is. So let's assume for a moment you're talking with a Medicaid plan, or you're talking with a Medicare Advantage plan. With Medicaid plans, the state has put out an RFP. Have you read it? Do you know what they asked for? If the responses are public, in most states they are, look at their response. What did they say they were going to do? And then look at what the requirements are there. Look at the members' benefits that they're going to get, and that's especially true under a Medicare Advantage plan, because they will certainly differ quite a bit more than typical under a Medicaid plan. But what's the model of care, too? If the plan is willing to share with you what their model of care under a Medicaid plan, that really helps you understand from the health side, but then crossing over into the social services that you do, what are going to be the requirements and expectations, time frames, and all those types of things, because it's all spelled out in there. So make sure you're looking at that. Make sure that you're looking at what the technology requirements are for you. If you're operating on 10-year-old computers and they're asking for technology that's state-of-the-art today, you've got a cost associated with that. Have you figured that out? Have you discussed it with them, or is that something you were already planning you needed to upgrade, and so this is helpful for you to know what you need to buy? So all those things are things to consider. Looking at the Medicare manuals, as well as this, what I've got on the screen here, the call letter. Call letter is an annual thing that comes out regarding Medicare Advantage plans. It tells the plans what's changing in the expectations for the future, the next year. So make sure you're looking at that. If you're talking with a Medicare Advantage plan, what was the call letter? What plans do they offer? What geography do they offer the plans in? All those types of things. Doing your homework before you go talk with them, or as you're looking at the contract. And understanding what they promise, and that's why you want to look at the contracts with the state or with the Centers for Medicare and Medicaid Services under Medicare. Identifying who the other network actors or the other providers in the network are. Do you have relationships with them? Or are these providers that you don't typically work with? All of those things help you to look at, is this a good fit, and how would the fit work between your organizations? And anybody that's ever worked with me before knows that I love these 5 questions: who, what, where, when, and how. Why sometimes, but hopefully the why question came early on. And why are you doing this? But when you're beginning to look at negotiating a contract, you want to ask yourself who, what, where, when, and why. When and how, sorry, about everything. So just taking care of transitions for a moment. Who's going to ID the members? And is it all of their members, let's say at a particular hospital, or are they only looking for folks that have been in for heart conditions, for example? Understanding that really helps you hone in on several things. So what is going to be the complexity of the person coming out in a care transition? It also helps you with volume. So if they're very specific, we only want people who have been in for their second heart-related condition, and they also have diabetes. Well, that's going to be a small volume, so you better start having a volume discussion with them. What is the volume going to look like in this contract? And that's just a couple of examples there. You also want to know who's communicating with the member, when they're going to communicate, and how that's going to be communicated, that you're going to be involved with this participant. Are you going to be expected to be seeing them in the hospital in a care transition before they go home for the hospital? And if you're not aware, that is certainly a best practice, that you're meeting that participant in the hospital before they go home. It really, really helps the transition work well. Well, who's going to introduce you into that scenario for the member? Because the member probably, if they haven't already worked with you in the past and aren't familiar with your working with the health plan, they may have a question. Okay, well, why are you involved? I'm dealing with Aetna or Humana or whomever. What is my area agency on aging or Jewish Family Services, whatever the community-based organization is? What is your organization's relationship here? So how is that going to be communicated? And that will really help you, because you need that person to agree to accept your services as part of the work you're doing for the health plan. And often that is one of the measures of success, is how well you are able to engage that consumer. All right. Now we're going to start looking at some general contracting provisions, and we're going to drill down on a few specifics as we go along. And this is where we start getting into what looks more like kind of like a checklist of things. And I'm going to hit on a few of these because I want to make sure I'm explaining to them. But all of these are important. So if I don't mention them, that doesn't mean they're not important. But I want to make sure we're leaving time for questions as we go along, or at the end, excuse me. So basic contracting provisions. The first one I want to touch on here is the second part of the second check there, evergreen provisions. Essentially, is this contract annually renewable unless one of the parties says, hey, we're going to get out? So there's a notice period there, and they're renewable. And I mainly raise that one because, especially for those of you that are inside a county or COG, Council of Governments, or a city, any type of government entity, some of those organizations have concerns about evergreen contracting. And so you'll want to flag those types of things for your legal counsel, and you may end up having to explain to the payer why you can't agree to an evergreen provision. I think they're a good thing for both sides if they're evergreen, but I understand that sometimes we have some challenges in getting some of those things done. Same thing with whole harmless and indemnification, especially, again, with government agencies. Sometimes there's a very specific way that agency is able to do those types of provisions, and sometimes there are ways they can't. So make sure you're looking for those types of things that may cause some heartburn as you go through the contracting review process, and look for ways that you can satisfy the legitimate need of the payer and also your organization to get these done. And it's been done all across the country with counties and with councils of government. There are ways to get through these things. Just need to be a little creative to make sure that everybody's happy and everybody's able to do things that they need to do. Hours of operation and response times. Those are often a very critical piece, and those are often not changeable for the plan. So the plan has either agreed with the state or agreed with CMS that under Medicare that they're going to have certain hours of operations and service availability. You need to look at that. If it's not in the agreement, you need to ask, what are your expectations on the hours of operation and service availability? Because your agency may be open, let's say, 8 to 4, where the managed care plan has, in their agreement with the state, said that they're going to be available 9 to 5. So you got to figure out how you're going to work with that and how you can adopt or adapt, at least for this contract, those hours. And if you have civil service or you have unions, then those are things that you're going to have to work through with those. But understand some of those types of things may be in the plan's contract with the federal government or the state government. So they may not be able to change it, and it may be something you've got to work through. So look for things like that in the agreement. Data use and ownership is also a very important one, because you want to be sure that you have as much ability to see the data, because the contract you sign today is the building block for the contract you want to sign tomorrow. And so being able to monitor your performance, perform at a high level, and be able to see your impact and be able to use that data is really important. As a general rule, the data will be owned by the plan or the health system, but you want to have as much use of that as you can. Obviously, anything that would be public is going to be de-identified. You're going to have to agree to those things, but be sure you're looking at what you can do with the data to further both the quality of the work you do, but also your ability to then use that to paint a picture for future contracts. On the right-hand side, I mainly want to touch on the fourth one down, performance expectations. And again, this is kind of a bidirectional piece as well. So back to that care transitions. When are they going to get you the name of that person that's going to leave the hospital, and how does that line up with your timeliness expectation? So if they say you're supposed to be in the home within 48 hours of the discharge moment, if they're not giving you the information about the discharge until 36 hours on average, you got a problem, right? So you want to make sure that those line up. Preferably, again, on transitional care, you want to be notified in plenty of time to be able to be in that hospital before the discharge. You certainly don't want to be behind the 8 ball where they have no expectation or performance requirements that they get you data by a certain time, so they're getting it to you at 36 hours in, and you have a requirement in the contract that does not stipulate that they had to get it to you more timely, and you're still going to be held to a 48-hour turnaround. And these are not hypothetical. I've seen these. And these are war stories from out in the field. So be sure you're looking for those types of things in contracts. Now, operational expectations, and that was a little bit of an operational expectation. But as we go through this, I'm going to first touch on the second one down, defining the work in detail. That gets back to that who, what, where, when, and how pieces. Who does what? And making sure that your requirements are listed clearly, but also their requirements, and how do those things mesh. So you want to think about real-world operational processes, and this is where you get your operational people, and even sometimes your frontline people. Get your all-star frontline people to take a look at how this process is going to work in the real world, because you got to make sure that you can make it happen at the end of the day, and that the questions have been answered either in the contract or and some of these things can be in more of an operational guideline. They don't have to be physically in the contract, but that should be an attachment to it, so that you have really clarified that who's doing what and when. Training is another big piece here. Who's doing the training? How much time is that training going to take? Who's paying for the training? All those pieces are really important. And the next one, volume and geography, I cannot stress enough how important it is for you to understand what is the volume and what is the geography. So let's go back to that transitional care moment where they want you to handle transitional care out of their members from the hospital. Well, do you know which hospitals you're expected to deal with their patients from? And are you expected to deal with their patients that may be going home outside your geography? And what is that expectation? So let's take a city that sits on the state border, but you, of course, as a AAA, most AAAs are going to be within a particular state and probably within a particular county or city. Well, if you're sitting on the state border, it's very possible that when that person leaves the hospital, they may actually be a member of the plan, but they're going to go across the state line when they go home. Are you responsible for going over there to see them in the home? And this happens a lot, even on a temporary basis. So the member may be going to a hospital in your jurisdiction, and they may physically live in your jurisdiction, but their son or daughter is where they're going to go for the first few weeks as they're recovering. That may be across state lines or even just across county lines into another CBO's jurisdiction. How do you deal with those things? So you need to make sure those pieces you fully understand and they fit within what your organization can do. And in some cases, you may need to reach out to sister community-based organizations and say, hey, I'm working on this contract. They want to cover this geography. I'm not really good at that geography, or I'm inside a county and they won't let me go outside the county lines. So I would love to bring you into this discussion. Could we do that? So thinking about some of those types of things. Now jumping over to the second column, staff qualifications. If they're thinking, as health plans often do, they're looking for a nurse, somebody with a nursing degree, and you're thinking social workers are going to do this work, maybe you got a problem. So you need to make sure that you have lined up staff qualifications and looked at your folks and whether or not they qualify. Sometimes you can do a grandfathering situation. I've seen that, where the expectation is that going forward, you'll meet X requirements if you hire new people, but that your existing qualified folks that have a track record of doing this type of work, that they will give you a grandfathering on those. Doesn't always happen. Sometimes, again, it might be in their contract with the Medicaid system that they have to meet certain requirements, so they can't change them. In other cases, they may have that ability and may be willing to be flexible. Then jumping down to the fifth point here, compliance. What is your role in compliance? In compliance with their contractual requirements, compliance with HIPAA requirements. And I'm going to talk about in a moment this downstream provider piece. All right. Next, though, we're going to jump over to pricing considerations. And specifically, when we start talking about pricing considerations, I'm talking about this as part of the negotiations and how to think about pricing considerations when you're beginning to negotiate a contract. And the big picture question is, what are you going to be doing and for what price? And so that's why you have to get fairly granular with your contract negotiations to understand that who, what, when, where, and how piece of this, so that you really understand what you're trying to price. And again, the volume and the geography and the related characteristics, like you're only going to be working with our heart patients that have diabetes. If that's what you're working on, is that something you're equipped to handle? And does that change the amount of time it'll take you to work with those members, those kinds of things? What are the staffing expectations we've talked about? IT systems, who is providing the system? So in some cases, the system, the payer may actually provide you the technology. They may provide your folks computers or Wi-Fi, MiFi type units to go out and we go out in the field because they want you online when you're going in the home. What are the complexities of the work you're doing? Then also the last one here, performance metrics. How are you going to be measured? A good friend of mine loves to talk about what does success look like. Make sure you're defining that, because you can't hit and you won't hit what you don't know in advance. And it's not fair for somebody to measure you based on a standard they haven't told you what that is. So get laid out, and this should be very specific. Here's what we're going to measure you on, and what success looks like. So is that hitting, so for being in the home, again, transitional care within 48 hours, if you have to hit that 100% of the time, or you're deficient, or is it the standard 95% of the time? What are the expectations there for your performance? And all of that you need to be thinking about as you're thinking about pricing. Now I'm going to talk about something that I think is gives a number of community-based organizations real heartburn. Because the way we price when it comes to government programs as well as grants and other funding opportunities is very different when we think about direct and indirect cost and that kind of thing, and rolling all of those pieces in, and that's how we build our cost models for those opportunities. Well, when you are looking at pricing in this payer-based world, it is a new world, and you are in a competitive system. That payer that you're talking with is looking at, or should we work with this CBO, or should we work with some other CBO, or frankly, should we build this in-house, or should we work with a home health agency out there or some other for-profit entity that can add this as a service that they deliver? So you've got to be cost competitive, and sunk cost is something that you'll hear if you're talking with finance people in the private sector that you need to become familiar with when it comes to pricing. And sunk costs are things that you're already, you have already committed to. And probably a lot of folks on this phone call are executive directors. Your salary does not go into the cost calculation. And the cost, if you've got a nice building there that you're already paying on, that cost does not go in the calculation. What you need to look at from a cost standpoint is what is the direct additional cost of providing that service. And that is your break-even point. And that's what you need to make sure that you're covering. And you need to figure out how much above that break-even point that you believe that you need to bring in. So what is that margin in order to make it worthwhile for your agency to do this work? That margin can certainly contribute toward executive director's costs, upkeep on the building, all of those types of things. But don't think about it when it comes to figuring out what the point is that doing this makes sense or not doing this makes sense. I've seen a number of times where organizations put that sunk cost in there, and if you do that, then your price will be your price would be high enough that if you can't meet that point, or let me say this a different way, that you walk away from what could otherwise be a very profitable, quote unquote, for your nonprofit or government agency piece of business with a payer. That and it's because of the way you calculated your cost structure. So please look at this, and a shout out for one of the Business Institute's funders, the SCAN Foundation. They have some great resources on how to think about this sunk cost piece. And the Business Institute also has resources, and there are links in those resources out to the pieces on the SCAN Foundation. There are other resources out there as well. But that's something, if what I'm saying doesn't make any sense, please look at that and get a better understanding of what those sunk costs are so you can really understand where it makes sense to bring in this work and where it doesn't. Now, performance. The most important thing on here is that timeliness is critical and customer satisfaction is critical. Looking at ways to assist them with things like their HEDIS gaps and other measures that the payer is under, where it's caps for the plans or HCAPs for hospital systems, all of those types of things, you need to understand those and you need to try to address them. The typical way that we have worked under Medicaid, for example, with or under some of our other state contracts, looking at billable units, that's not the way that a health plan or a healthcare system is going to look at performance metrics. They're going to look at outcome. Now, when should these things be defined? Those metrics should be in the agreement. They may be in the scope of work, not in the actual master services agreement, but you want to get those defined as you're negotiating this contract, because what those performance metrics are may be directly related to how you price your services, because they could add costs. So, for example, if they expect you to spend at least 2 hours in a home doing an assessment, and they think that's the standard, and you're used to spending an hour in the home doing an assessment, all of a sudden you're pricing based on an hour, they're thinking based on 2 hours. You got a performance metric issue. If they're expecting you to be in the home within 48 hours, no matter whether it's day or night, weekend, whatever, you're going to have to pay overtime probably for those evenings and weekends, right? You better figure that into your pricing. So make sure you have those performance metrics defined at the time you're negotiating the agreement. And it is never acceptable to leave those performance metrics out to be determined unless it also comes with pricing readjustment. So if they're gonna pay you more if their expectations don't meet yours, that's one thing, but that's rarely the case. They're going to want to hold you to the pricing that you agreed to, and if they change the performance on you later, you've got a problem. Now, as I was preparing for this, I realized that last bullet is a little misleading, so let me explain that. Performance metrics can be adjusted prospectively. So I want to make really certain we're clear that not retrospectively, just to be really clear. So if you set down performance metrics and then you go in and you're 6 months in and even 3 months in, you may together, as you're working together, realize what you set out as performance metrics really aren't realistic. So it's fine to sit down and adjust those. If you do, make sure that you're party to those adjustments, and if it affects your cost, that then a pricing consideration needs to be on the table as well. And we're going to talk about compliance. And just so we're clear, I say the really best parts for last here. So FDR, first tier downstream and related entities. Many of the Medicaid plans operate under similar state rules. You see here, this comes out of Medicare Advantage and Part D plans, but if you're talking with a Medicare plan, and in a lot of states the Medicaid system, you're going to have to, this is going to come up, first tier, downstream, and related entity. Now, what does that mean? A first-tier entity just essentially means that you're directly contracted with that plan. You're the first level, and they contract with you. And a CBO that contracts directly with a Medicare Advantage plan to provide services like care coordination to their members may also then have contracts downstream from them to manage the network. Those would be downstream providers. I will say in some places downstream is often used generally to include both first tier, but the main difference is first tiers are contracted directly with the plan. Downstream is anything down below that there's a contract down to somebody else to do something. If you contract with a plan to also contract some of those downstream providers, so let's say it's for transportation or meals or personal assistance services, and you're going to contract with those, you may be taking on delegated requirements there where you're now taking on the risk of that downstream provider being out of compliance. So you have to figure into your role in your cost structure, your oversight of that downstream provider as well. And that's probably the most important thing to think about with first-tier downstream and related entities. The related entities just means that they're related to the plan. So think of that as the Aetna and CVS relationship. Is, if you're not aware, CVS bought Aetna, I think about 2 years ago. And so they are clearly related entities, and so that's what that's talking about. So from a big picture standpoint, if you contract with a plan as a downstream entity, and then part of that agreement is that you're going to contract with others downstream from you, you're going to be responsible for the performance of those downstream providers that are at the network. And is typically the way a lot of CBOs operate. Certainly the AAA system often does the assessment and the coordination, but then they'll have contracts with other providers that actually deliver the services. If you take that model and contract with an MCO to do that, you're now fully responsible for those downstream providers and their compliance. So think about that compliance piece. Make sure you understand what you're agreeing to do and that it comes with some serious compliance responsibilities and requirements, and it's really important that you understand what those are and that you've contracted appropriately for those. And now last, we're going to talk a little bit about data security. And you want to start your thinking here with what system are you using? Are you going to be operating in your system, or are you going to be operating in their system? As much as you can, you want to operate in yours, but if you do, you got to make sure that your system meets full compliance standards for privacy and security. And I mentioned before training. Who's paying for that training? Who's doing that training? What are the cybersecurity protocols, and what's the testing? Are they going to come in and audit your system? Are they going to require you to have a pen test? And if you're not aware of that, that's a penetration test. And that's where you have an outside organization that's expert in this to actually try to hack into your system. And what were the results of that pen test? How often do you have to have those done? Staffing. There's clearly onboarding. You've got to do training there, right? But what happens when somebody leaves your organization, and how do you make certain that they're not walking out the door with any information, whether that's paper or online types of information regarding PHI and other secure information? Succession policies. What happens if your director of IT walks out the door tomorrow? What do you have in place? Do you have policies and procedures? Who takes over and how you make that seamless? Because with contracts that managed care organizations or health systems have with the state or the federal government, the dog ate your homework is not an answer the state or the feds are going to accept. So you need to make sure that you can be seamless in your operations. You need to know what the file retention and backup requirements are, what the data processing requirements are, and what type of cyber insurance do you have to have in place. Back to thinking about offboarding, so when somebody leaves, do you have the ability to remotely wipe their system? So let's say they walk out the door today and you never see them again. They've got a computer. You've given them access on their cell phone to your information system or their tablet, and how are you able to wipe all that information right off their computer? That's going to be part of the expectations of your contracts. MFA, or multi-factor authentication, is becoming more and more of the standard out there. If you've not already seen that, make sure you understand what that is. And do your computers, smartphones, tablets, those types of things, do you have those requirements in place? And then data security policy expectations. You want to make sure that you have documentations covering the standards and practices for use of all the data and technology, the internet, all those types of things under that acceptable use policy. What are you doing regarding protocols and ownership of this information? Where are you storing information? So let me just, something that often gets forgotten. Let's say you use one of the cloud-based services. You've got things out in Microsoft SharePoint, or you've got things on Box.com or Dropbox or Google Drive. Do you know where that data actually is being housed? Is it sovereign? Is it within the United States? Do you have guarantees for that? Have you signed agreements that with those cloud providers that they will comply with HIPAA standards with your data? All of those things those are questions you're going to get asked by the managed care plan if you're the one housing any of their data for their members. What are your disaster recovery plans? You probably have those for your physical files, but what about your virtual files? And system and software updates. What are the requirements? What are the expectations? Do they expect you to have all of your software like your Microsoft Office on auto update, or are you able to push those out into the systems using your IT vendors? So hopefully by now we probably have some questions out there, and I've hopefully generated some thinking about what is ahead in that windy road you see on your screen now. And the good news I'll leave with you on that is that you're not traveling this alone. There are a lot of other CBOs that are out there that have done this type of work and have experience, and have been very willing to share those experiences through the Business Institute, through ASA, and other organizations like ours out there that can help you as you travel this winding road. And I'll leave you with this saying that I love this because change is going to happen, is the bottom line of what I'm trying to get across here. If you're sitting on the fence or on that picture on your screen, if you're sitting on that yellow line out there and thinking, I'm not going to do anything, change is happening to you. Sitting still on that center line does not mean things will stay the same, and it's a great way to become roadkill. So get out there and talk with MCOs and health systems and look for opportunities, ways that you can further your agency's mission. I cannot think of a time in the last 35 years that I've been doing this kind of work, I cannot think of a single time that opportunity is not greater than it is today. It's just a matter of being prepared and looking for the right opportunities that fit your organization. And with that, Steve, let's open the floor with any questions that you may have.
That sounds good. Thanks a lot, Paul. Really great presentation. Yes, everyone, if you have any questions, now is the time to send them in. We're going to segue into the Q&A portion of today's webinar. So send in those questions for Paul, what we've been talking about here. Paul, the first thing, let's follow up on what you were just saying a second ago about this being the best time for opportunities that you have seen in quite some time in your extensive experience. Why is that right now? What is it about right now that makes this the best time that you were just mentioning?
Well, I think we could probably talk for an hour on that one question, but I'll give you a couple of things. One is under Medicare Advantage, the federal government has, a couple of years ago, relaxed some of the requirements of what Medicare Advantage plans could pay for within their overall financial structure with the federal government. And SSBCI, and at the moment that acronym is skipping my mind what it means, but go out on the Business Institute website and search SSBCI. I worked with Mary Kashak, and we wrote a blog post on this, and I know it's out there, and it'll describe that a little bit. So there's a renewed opportunity, and the federal government, each year has expanded that opportunity to be able to cover some of those services under Medicare Advantage plans. Second, under Medicaid, there are more and more contracts every year of managed Medicaid plans working with CBOs to deliver value. So there's more openness on the Medicaid side to being willing to do this. Also, if you're reading any of the health policy things and research that's coming out, there's just a plethora of information talking about the importance of social determinants of health and how that positively impacts the health of people at risk, so older adults, people with disabilities, people with chronic conditions, and the ability to address those social issues really can improve health. And that leads to the people who are responsible for paying for that health, especially on the managed care side, but also in health systems that have taken on risk. All of those organizations need help addressing those things. And I'm going to stop there.
Okay, thank you. Next question, Paul. How motivating do you think shared risk arrangements are to healthcare entities? And second part of that question, do you think that being prepared to accept risk makes a CBO more appealing?
I'll answer the second question first. Absolutely. And it is only partially the idea that they want to share a risk with you. It's more philosophically that you are thinking that you're willing to essentially put your money where your mouth is. That is important to managed care organizations and health systems, that you're willing to do that, because that's what they do every day. They're in the business of accepting and managing risk. And your ability and willingness to do that is something that they want to get to. And I'm going to say that with a big but. If you don't already do some of this contracting and don't have a really, really, really good handle on exactly what you're going to be doing and what the expectations are and how your systems are going to operate, and just all of the things we've been talking about today, don't accept risk to start with. If anything, accept upside risk but not downside. So basically incentives that you might get but not a downside cost. The last thing you want to do is put your CBO into some type of financial risk because you accepted some type of risk. So be really careful doing that until you've gotten your feet wet and know what you're doing. Most managed care and healthcare systems, they don't want to put you into financial harm either. It's more a philosophical thing that they want you to have skin in the game so that you are really striving to be as efficient and as high quality as possible. And accepting risk is one of the ways you show that. But they're not going to want the headlines in the paper to say this CBO closed its doors because the mean health system or MCO put us out of business because of the risk arrangement. And that's not good for them either. So they're going to want to work with you. So I wouldn't say, if you haven't done this before, don't come to the table to start with that, but you need to be open to the discussion.
Okay. Next question. You've mentioned that privacy and security issues, such as having access to sensitive information remotely by employees. Should we have that stated in a contract, and how can that issue be presented in a written format?
As a general rule, you need to be looking at what the requirements are, and this is something to ask relatively early on in your discussions of a particular project with a payer, what their requirements are going to be as you start to talk about, well, okay, whose systems are we going to operate in, and what are the expectations, and how would we exchange data and all that. Ask them for what are their compliance and security measures. So what type of process are you going to have to go through? Because they will put you through a process where you're going to have to go through and you're going to have to verify, I do this in this situation, I do this in this situation. Here's where we house data. Here's all those types of things. Here are our protocols regarding onboarding and offboarding and all those types of things. I don't want to leave you with the thought that you need to have all those questions answered going into the discussion, but make sure you've thought about them on your side so that then when they will present you what their expectations are, and you need to make sure that you've thought about it so it doesn't hit you out of left field.
Okay. Paul, next question. CBOs typically seem to look to hospitals and hospital systems for contracts, but their incentives are still often not aligned with the outcomes CBO services are designed to create. How likely is it that health plan will contract with a local CBO versus a national vendor for meals, et cetera, versus the idea that a hospital will contract for the same service?
Mm-hmm. I think it somewhat depends. Some of the MCOs are much more willing to contract locally than others. I will say that they are all very much, that they love standards. So they love to be able to do one thing in one place that they can then replicate somewhere else, because scale is how they create efficiencies. And certainly scale helps you as a CBO as well. And there are certainly organizations out there that are trying to create some of these standards and scalability pieces out there. I would say that things that can be replicated nationally, meals are one of those, and certainly Meals on Wheels, I'll give a shout out to them. They've done a lot of work in this area. But if you're a local meal provider and you're not affiliated with some type of national organization that is able to do these types of contracting, either that national organization that the plan contracts with, and there are a couple of them out there that do this, you'll have to try to contract with them, which means they're going to take a piece of the finance, which makes it hard to make the dollars and cents work at the local level, or it's going to be really difficult. So let me just rephrase that. If you're not working with some type of national organization, if you're a meal provider or something like that, transportation's the other big one. You need to look at, can we go this alone, or do we need to align? with one of those national hub type models, or at least a regional one, if you're going to contract with the plans, unless it's a regional plan. Contracting with the health system, biggest question there is, are they taking on risk? Back to the last question. If they're taking on risk, then you probably do have a conversation with them. That's where they change and start thinking more like a payer.
Okay. Well, Paul, unfortunately, we've reached the end of our hour here and we're out of time, but I want to thank you for joining us today for a great presentation. Thanks so much.
Thank you, Steve.